Good afternoon, everyone. Today we will discuss anti-inflammatory drugs. We are going to start with the pathophysiology of inflammation. And just as the definition, inflammation is a localized protective response stimulated by injury to tissues. It has the classic signs, and everyone is familiar with these classic signs of fever, pain, loss of function, redness, and swelling. We have a diagram that's available for you guys in my courses, and it really goes into detail describing the process of inflammation, which entails the arterial, venous, and capillary dilation, which then leads to your increased blood flow to the specific area of inflammation. And then that leads to the vascular permeability. The inflammation is mediated by what we know as the complement system. The complement system is incorporated by your histamines, your serotonin, your bradykinins, your leukotrienes, and your prostaglandins. And all of those are part of the complement system, which help to mediate the inflammatory process. Now, getting into specific medication that deal with your inflammatory process and anti-inflammatories, as they are known as a category. We start with the first generation of NSAIDs. And for your knowledge, NSAIDs does stand for non-steroidal anti-inflammatory drugs, and so these three, the first three, aspirin, ibuprofen, and naproxen, are over the counter. The others are by prescription only. So your indomethacin, your diclofenac, your ketorolac, and your miloxicam are all by prescription only. Your ketorolac is known as your, the generic name is Toradol, and it's used for mild to severe pain. It can also be used in conjunction with opioids, which help to give it the synergistic effect, so it helps to stimulate the action of the opioid. Your second generation NSAIDs, like your celecoxib, is used for pain for chronic inflammation, diseases such as osteo or rheumatoid arthritis are diseases where those second generation NSAIDs are more prominent to be used. Your mechanism of action for your NSAIDs is that they do inhibit the COX-1, which maintains GI mucosa. So it has a decreased platelet aggregation, which is what your aspirin does, which is one of the over-the-counter NSAIDs. It also will decrease the protection of the GI mucosa. So you will then have an increased production of acid in the GI tract, which will then decrease the secretions of protective mucus. So taking too many NSAIDs will lead to GI upset, basically. The other mechanism of action is you have an inhibition of COX-2, which is the inflammatory response itself. These inhibit the leukotriene and or the prostaglandin pathway. These will decrease inflammation, fever, and pain. So those are the meds that are specific to wanting to decrease the inflammatory response. NSAIDs will have a ceiling effect, meaning that more med does not mean that you'll have more of an anti-inflammatory effect. So just taking more milligrams doesn't mean that you're going to have a better effect of it. Why we use NSAIDs? All NSAIDs will suppress inflammation. They will provide pain relief and fever reduction. Aspirin is one of those NSAIDs that also have an added feature of inhibiting the platelet aggregation, which is why we give it at the first sign of an MI, because it does help with platelet aggregation, and most of the time MIs are usually caused by some type of clot, and so it can help to prevent or at least reduce the signs of that MI. So those are most of the main uses for NSAIDs. Adverse effects that you will see with NSAIDs. So, as I was saying, one of the adverse effects, or some of the adverse effects that you will see with NSAIDs is GI discomfort, because again, it inhibits COX-1, which then strips away the protection of the GI mucosa, will lead to GI bleeding, perforation, especially with long-time use, which that is one of the black box warnings on those over-the-counter NSAIDs. It will have impaired kidney function, so you will see a decrease in the urine output, fluid retention. You might have weight gain, increased BUN and creatinine levels, and you will see an increased heart attack or stroke with those NSAIDs that are non-aspirin NSAIDs only. So you use the smallest effective dose for clients who have a cardiovascular disease condition, and that is also a black box warning, so that is important for you guys to know. And then for aspirin only, you will see silicism, and silicism is a condition that has tinnitus, sweating, headaches, dizziness, respiratory alkalosis. If you stop taking it, signs and symptoms will occur. So if you do see these symptoms, you need to stop taking if the signs and symptoms occur. You could also see with aspirin Ray syndrome. That's why we don't give aspirin to children or adults less than 18 years of age. Because Ray syndrome does tend to happen or occur in the younger population more than in the older generation. So in the older population, you do see more aspirin toxicity. So silicism, the signs and symptoms do progress into hearing loss, hyperventilation, nausea, vomiting, CNS effects. So it can lead to a coma. Now with celecoxib only, it is the only COX-2 that's still on the market due to the cardiovascular events. Less GI effects since it doesn't affect the COX-1, but little effect on the platelets. It does have a suppression of the vasodilation, so it does have an increased risk of MIs and stroke. And that's why celecoxib is the only COX-2 NSAID that is still on the market. The other thing I want to mention also is that with these adverse effects and with impaired kidney function, NSAIDs do cause arterial constriction, leading to decreased renal perfusion and decreased GFR. So you will have an increased risk of renal toxicity in those patients who already have a decreased renal perfusion, such as patients with dehydration, heart failure, liver dysfunction, those patients taking diuretics or ACE inhibitors. So these are patients that you need to be cautious with when giving NSAIDs for long periods of time or in large doses. Now, contraindications for NSAIDs. Your first gen contraindications, of course, first is going to be pregnancy. It does inhibit prostaglandin which interferes with the heart development of the fetus and can cause bleeding also in the mother. It can cause patients with peptic ulcers or bleeding disorders. Those at risk for bleeding will have increased bleeding with NSAIDs, so it is a contraindication. You want to be cautious in giving NSAIDs to older adults, smokers, patients with H. pylori, patients who are hypovolemic, have asthma, have some type of chronic urticaria, or are alcohol abusers. They will all have some type of ill effect from the NSAIDs. The ketorolac, which is your Toradol, you do not want to use for longer than 5 days. It can have advanced kidney complications, and those patients with advanced kidney disease are then at even greater risk of advancing their disease process. So you want to be cautious of that. You also want to make sure you read or make your patient aware of the black box warning, especially for those non-aspirin NSAIDs. The cardiovascular risk is an increased risk of clots, so you are at increased risk for MI or stroke in as early as 1 week of use of NSAIDs, and of GI bleeding, ulcers or perforations are also part of your black box warning. And this again is very important for you guys to know. And then with aspirin, again, those patients under 18 should not be given aspirin because of the Reye syndrome. Excuse me. Your contraindications for your second gen celecoxib, again, you want to be cautious with patients that have some type of cardiovascular disease, and any patients that have an allergy to sulfonamides. They do have a very similar structure as the sulfa antibiotics, so you don't want to give it if they have an allergy to the sulfa drugs. Other caution that you want to take with NSAIDs, patients who are older, clients with heart failure, because with heart failure it can cause more fluid retention from impaired kidney function, because again, NSAIDs do have a higher risk of causing kidney dysfunction. You want to be cautious with those clients who smoke, who abuse alcohol, or have some type of previous history of peptic ulcers or the inability to tolerate NSAIDs that they've taken in the past. Interactions with NSAIDs, there are a few. If you have patients that are on any anticoagulants, heparin, warfarin, they will have an increased risk of bleeding, so you will need to monitor their PT, their INR, their PTT. You want to notify the prescriber, especially if you see an increased bleeding. NSAIDs may counteract the cardioprotective aspects or the cardioprotective effects of aspirin. So you want to also take that into consideration as well. Patients who are on any glucocorticoids do have an increased risk of GI bleeding as well. So they should take the misoprostol prophylaxis in order to help prevent that increased GI bleeding. Patients who abuse alcohol or are taking alcohol, again, they also have an increased risk of bleeding from the NSAIDs. Ibuprofen does decrease the anti-platelet effects of aspirin used to prevent the MI. So they should not be taken concurrently. And those patients that are taking diuretics or ACE inhibitors have an increased risk of renal toxicity. So that's an interaction that you also want to take into effect. And your ketorolac should not be used with any other NSAIDs because of the increased risk of any adverse effects or the doubling or increased risk of bleeding. And this is also important, especially when you're using the ketorolac as a synergistic effect. So like if you're using it with an opioid for breakthrough bleeding, you don't want to give an NSAID. You don't want to give the Toradol and then the Motrin in less than a 6-hour difference because it will increase their risk of bleeding and adverse effects. Nursing considerations that we need to take into mind when we are giving NSAIDs is that you want to make sure you're monitoring your I's and O's, and you're monitoring your urine outputs. Labs that you want to look at is your renal function labs, your electrolytes, so like your sodium and potassium, your hemoglobin and hematocrit levels, your red blood cells, your platelets, all need to be monitored. You can have a decrease in sodium and an increase in potassium with NSAID use because of the renal dysfunction that it is prone to cause. Your non-aspirin NSAIDs, you want to use your smallest effective dose if they have some type of heart disease. So that is also important, and it's a nursing consideration that you need to look at. Age-appropriate considerations that you need to remember is, again, you do not want to give to younger than 6 months of age. Any NSAIDs, caution in the older patient because of they may already have a reduced renal function, and then you're giving them NSAIDs, which can cause a worsening of that renal dysfunction. Again, aspirin itself, you do not want to give to younger than 18 years of age. You want to make sure that you are looking for or monitoring for aspirin toxicity. With aspirin toxicity, it is a medical emergency. You want to be able to have activated charcoal and or gastric lavage available. You might need hemodialysis. You might also you want to be able to have available to cool the patient with tepid water. You want to have IV fluids, bicarbs. You want to be able to promote salicylate excretion. So all of those things you want to be able to have available in an emergency if you do notice aspirin toxicity. With IV ibuprofen, you want to infuse it over 30 minutes to ensure that the patient is well hydrated prior to the administration is also important. With the ketorolac, again, if it is taken with the opioids, it will help to reduce the opioid dose. So, meaning it's because it has that synergistic effect, you don't have to give as much opioid in order to get it to work effectively for the patient, because you're giving it along with the Toradol. Do not give for more than 5 days, again, because of the risk of kidney damage. And you want to administer with the misoprostol PRN because it will help to protect the mucosa, since if it is a COX-1 inhibitor, it will have GI or mucosa effects that is part of the mechanism of action with this medication. Teaching for the patient, things that you need to remember. Again, you want to take medicine with food or at least 8 ounces of water or milk. It does decrease the GI mucosa, so it will lead to irritation. You want to administer with a PPI or an H2 receptor antagonist, again, to help reduce the risk of ulcer formation. You want the patient to avoid alcohol. You want them to be able to know that they need to report black tarry stools, any bleeding gums, petechiae, or easy bruising. These are all signs of increased bleeding or signs of bleeding in the intestinal tract. You want to be able to stop NSAID use 1 week prior to any type of surgery, again, because of the risk of bleeding that it causes, especially patients that are on aspirin. You want them to know that they need to notify the PCP and stop taking the aspirin if they notice signs of salicylism that is occurring. You want them to know that they do not chew or crush any enteric-coated aspirin tablets because it defeats the purpose, of course. You want them to know that prophylactic therapy for CAD or stroke requires aspirin to be given either 81 milligrams or 325 milligrams, and that is usually every day. You do want them to know to report any, again, signs and symptoms of salicylism or toxicity. With NSAIDs, you want to make sure you may take 7 days for anti-inflammatory effects. With NSAIDs in general, not just aspirin. And again, education regarding the black box warning is very important. Okay, and like I said, education regarding black box warning is important for the patients to know. Again, you may take NSAIDs with food, milk, or any antacids to minimize the GI upset. Your signs and symptoms of aspirin toxicity, again, are going to include tinnitus, hearing loss, increased heart rate, dizziness, mental confusion, and diarrhea. These are all signs of toxicity that you need to be aware of, and teach your patients to be able to also report that to their primary provider. You want them to know to report black tarry stools or bleeding gums, any signs of bleeding that will show that they have an increase in that bleeding. And again, the adverse effects, they're not allergies, but they're adverse effects of the NSAIDs are going to be your dyspepsia, your heartburn, your GI bleeding. Most important important for you guys to remember is that pediatric patients and teenagers are never to take aspirin because of the Rye syndrome. And again, to make sure that aspirin and any other NSAIDs are discontinued 1 week prior to any surgery. And again, may take 7 days for anti-inflammatory or joint pain for the use or the effects of NSAIDs. So these are all patient-centered teaching that is going to be important for you guys to be able to teach your patients about NSAIDs. And that concludes our NSAID lecture. And if you have any questions, don't hesitate to reach us by email or at the end of class. Thank you.